This is a talk about addressing overtreatment and defensive care. It's about helping patients in a way that is meaningful to them and their families. It's about helping our patients achieve their goals safely, no matter how high the risk is. This is an important topic for anyone working or thinking about working with older adults. It's also an important talk for anyone that plans to be old one day. We have the chance to have a huge impact on our patients, but that impact can be positive or negative depending on the decisions we make. So, without further ado, let's get into it. How long have you gone without drinking? My best friend growing up was Jewish, and I would celebrate Yom Kippur with him and his family. For those of you who don't know, during Yom Kippur, you fast from sundown to sundown. Nothing to eat, nothing to drink, not even water. You can't even brush your teeth. Picture doing this for months. Nothing by mouth, no drops of water, no ice, no nothing. Secretions dry up like the salt in the Dead Sea, and you feel like you would do anything for anything to eat or drink. This is the unfortunate reality of many of the patients we serve. Treating older and younger patients the same is inherently flawed. Compared with their younger counterparts, older patients tend to have issues that are more chronic and difficult to resolve. So the overall risk, of course, rises as you age. Something else to consider, though, is that older, more fragile patients may find it difficult to look ahead past their condition toward a time when they will be independent again. So, quality of life concerns also grow with age. Because of this, treating older and younger patients identically would be like bringing a basketball to a baseball game. The rules just aren't the same. Why did I put this presentation together? I recently saw a patient, let's call her Renee, who was highly medically complex. She was on the vent for years, in and out of hospitals, with a long standing history of chronic disease with recurring aspiration pneumonia. All she wanted was ice cream after months of NPO status. Nobody thought it was possible to get Renee on any PO at all. And in fact, I got a lot of pushback even from my own team, but we got Renee that ice cream, and we did it safely too. My goal is to dig into the facts behind NPO status and overly restrictive diet modification measures and create a guideline that can help us replicate the impact that we were able to achieve for Renee. Because my dream is that everyone who can will eat. Today, we are going to define the problem and explore how we got to a place where we feel the need to recommend modified diets before anything else. And then we'll talk about the solution. What's a better approach to what we're doing right now? Finally, we'll discuss a path, a guideline to identify and overcome barriers in your facility so you can achieve your goals to get your patients eating and drinking safely when the risk is high. In the next video, we'll be talking about the problem. I'll see you there.